Hello, everyone. My name is Lupe Sanchez, and today I'm here with Dr. Esparza, and she is going to introduce herself and then tell us about her career.
All right, I'm Dr. Sandra Esparza. I am a family practitioner. I had my own practice for 17 and a half years, and now I do telemedicine. So I do what I did in office through a video format, similar to what we're doing now. I
Mm.
see all ages of patients. I see from newborn up until geriatric. So my oldest patient was 101, and I'm able to see everybody in between. The only time I don't see them is when they're pregnant. I usually send those off to OBGYN, but family practice actually can see pregnant women as well.
Oh, actually did not know that. How was the transition between assessing your patients in person to assessing them online?
It's pretty different. It's more difficult for me because I tend to like to know patients really well, and it's nicer to see them in the office, get to know them, know their families. On telemedicine, I don't really have control of seeing the same patients over and over, so they're typically new patients to me that just kind of pop in from all over the country, and usually they're ill, and I'm not managing chronic disease. Although some of them, especially during COVID, have not been able to see their regular doctors for their diabetes checks or their high blood pressure or high cholesterol. And I'm managing those diseases for them while we're in this kind of weird quarantine type situation.
Are you planning on keeping on consulting virtually after COVID gets controlled, or are you planning on going back to the office?
That's a good question. Right now, everything's kind of up in the air. I don't know. I have lots of options because I think telemedicine is going to stay around. I do miss the kind of touch aspect of being able to sit with somebody in the office and kind of when they say their stomach hurts, I can actually do a good exam and all of that. I do volunteer at a free clinic, so I get some of that every other week. So I don't know quite where my future lies at this point.
So what set off that transition for you to go from in person to virtual?
So COVID obviously was the catalyst for that. We had never, and I had never really thought about doing virtual care. I think a lot of people look at it as kind of bad care because we can't touch the patient. We can't do what we would do in the office. So it was never on my radar. But when COVID hit us, we had to transition within my own office to virtual care, and because my husband and I had our own clinic and the numbers went down and affected us financially, we went ahead and started looking for other positions. And because nobody was really hiring in person at that time, back in April, May of 2020, uh, virtual care was my best option.
Mhm. I was just wondering how you think that your major from Southwestern guided you into the career you're doing today.
So I majored in biology. I went in wanting to go on to medical school, and that's the path that I stayed on. And so it definitely prepared me with all the basics that I needed to take the MCAT and to go ahead and enter medical school. I always say that everything you learn in undergrad, you learn in the first 2 weeks of medical school. So it's very different. So a lot of people worry about, I didn't major in biology. I didn't take as much biology as somebody else. It doesn't matter. When you get to medical school, you're kind of retaught everything at an accelerated pace. And it doesn't matter what your undergrad degree is. I think as long as you take the basics so you can pass your MCAT and do well.
Awesome. Um, can you tell me a little bit more about your med school experience?
Sure.
Mhm.
So med school was taught a little bit differently when I went to school than it is now. They were in the transition phases because everybody kind of follows the big schools like Harvard, and Harvard had kind of implemented this new program where they did kind of organ-based learning. So when I went to med school, the first year you learned all of the normal, like how the body works. So you did anatomy and you dissected and you saw how all the cells worked and biochemistry and how everything worked perfectly. Second year was all abnormal, was all the pathology. So we learned all the diseases, and then you did microbiology of all the diseases. And then by the time you got to third year, you knew how the body should work, how the body doesn't work sometimes, and then you get into more treatments. Although second year you learn pharmacology as well. So third year was all clinical, fourth year was all clinical, and then you decide where you go for residency to train some more.
How did you decide what residency you wanted to go into?
That was hard, actually. I liked emergency medicine a lot because you got to do a little bit of everything and you got to do a lot of procedures, and that was really kind of my thing. I really like to do those things. But what drove me crazy about emergency medicine is you just never knew what happened to the patient. You could send a patient for a CAT scan and say, "Oh my gosh, he has a big brain tumor. We're going to send him over to MD Anderson," and then you just kind of like, I wonder, what they found or what they did or how he is, or, you just never really knew what happened once they left the emergency room. So family practice has the ability to do a lot of procedures. They see all ages and all demographics. So I liked that. And that's why I chose family medicine, because you also get the relationship with the patient. So I could follow patients for years, and sometimes would see their parents and their children and their grandchildren. So you kind of know what the family dynamic is and what's going on in the family. And sometimes, you'd have a grandchild that had cancer, and you would know how much that was affecting their health too, as the grandparent or as a parent. So you could kind of know what was going on in the family that affects their health in general.
So from what I've gathered, I feel like from family medicine, you get really, really close with the whole family. How were you able to cope with like when you lost a patient that you were really close with?
Mhm. It's always difficult to lose patients. It's and even when they're older and even when they've been sick for a long time, losing a patient is difficult. You do become emotionally attached to them. You have to separate yourself a bit to not feel like, to not go into a deep mourning over some of these patients. It's very difficult. So you don't completely remove yourself from the situation like you do when you're working on a patient. So in emergency medicine, you're working on a patient, perhaps they're coding or they're dying in front of you, and you have to kind of turn all of the emotions off so you can think straight and you can work on them. In family practice, a little bit different because you're not necessarily working on the patient as they die, although you have to have deep, hard conversations sometimes, and end of life care is an important aspect. You have to sit down with them and their family members and kind of have those conversations that nobody really loves to have about what do you want? What do you want towards the end of your life? And those are always difficult conversations to have. But when you have a great relationship with somebody, it makes it a little bit easier. It's not as cold. It's a little bit better to have those with somebody you trust and you know.
Yeah, I could imagine how it's better to have that conversation with someone you already have a relationship with and who's probably been seeing other family members. Um, when someone has like oncology cases, do you manage those as well?
Oh, absolutely. So on oncology, when somebody's diagnosed with a cancer, they go and they see their oncologist for the cancer, but that doesn't stop them from needing all of the other routine care. So when they're sick with a cold and they're sick with this and that, and say they have diabetes and they have cancer, or they have high blood pressure and have cancer, the oncologists are very good about trying to manage what they can when they see the patient, but they won't manage their chronic care necessarily. They usually still have to be seen. So we work very closely with the oncologist, and sometimes they need medications that perhaps will damage their diabetes. So we have to kind of talk about which is best for them. Is it more important that their diabetes is under good care, that their cancer is being treated in a certain way? So there's lots of conversations. Oncology is probably one of the closest that I work with in my practice.
Mhm. So with telemedicine, do you get to still work really closely with other physicians? or how do you go about that?
Not so much because I do mostly urgent care. Like I said, during this pandemic, it's a little bit different, but usually they call in because, I woke up this morning and my head is congested, or I have a cough, or, do I need to be tested for COVID, or my stomach hurts, or I've been vomiting. So it's usually not a whole lot of kind of chronic conditions, like I said. But it's a little bit more difficult to work one-on-one with because we're out of town, and I see patients on the East Coast a lot. And I don't know a lot of the local physicians. When you work in your clinic, you get to know who you refer to. So it makes it a little bit, a little bit easier when you're working locally.
Hmm. Okay, that makes sense. Do you mind sharing some skills that you think that Southwestern really enhanced for you?
I think Southwestern really improved my critical thinking. I think that learning to kind of learn in an open-minded way where you're really always exploring different options is a really good skill, especially in medicine, because you may think you know what's going on, but you have to kind of keep open, like it could be this, it could be this, it could be this, and that way you can explore different options and different paths. So I think that's one of the things, the kind of the critical thinking skills that I picked up at Southwestern were most helpful for me.
What do you think is the most common chronic disease that you've encountered?
Probably diabetes and high blood pressure. High cholesterol is kind of right there too. And I work with a largely Hispanic population because I'm a Spanish speaker. So diabetes is a huge issue. I'd take that back. I would say obesity is probably the largest issue, but those then lead to diabetes, high blood pressure, and high cholesterol.
Um, I have read some stuff, and it's common knowledge that the Hispanic population does have to have higher rates of obesity and diabetes. From a physician's aspect, what do you think is the reasons why the Hispanic community has the higher rates of obesity and diabetes?
Yeah, I think it has a lot to do with diet. I'll tell you, my mother grew up in Mexico, and when she came to the United States, she was amazed that people ate salad. That was a topping for a taco. I mean, that's really kind of what it is. Like, who eats lettuce and tomato, and it's just a different diet. So eating refried beans and fried tacos and those types of things obviously are not ideal in a diet. So when an ideal diet is more the Mediterranean diet, and that's not always on the list of, and you tend to eat what you grew up with. So if you have always eaten, a certain type of food, you tend to stick with that. You don't know what else to eat.
How receptive are the patients to actually changing their diets once they are diagnosed with
Yeah,
diabetes?
I mean, I think it's very individual. There's some people who are very motivated and saying, I don't want diabetes. I'm going to do everything I can to change that. And if I need to lose weight and if I need to eat differently, I will. And then there's patients that just say, well, give me some medicine. And mm, yeah,
It's really up to each their own.
that's right. That's
um,
right.
being able to, as you mentioned earlier, that you're a Spanish speaking physician, what are some of, like, I guess, the benefits that you've seen to that? I'm sure there's plenty.
Well, absolutely. People like to conduct their healthcare. Even people who speak pretty good English prefer going back to their native tongue to talk about healthcare. Those are more personal things. They feel more comfortable in their native tongue. So I think it's a huge benefit. I recommend that anybody who wants to practice medicine in Texas and probably the Southwest and now just about anywhere. Learn a language, and Spanish is a great one in this area, because even when I have medical students that come into my office and say, well, I don't really speak Spanish, but I speak, a tiny little bit, I say, do that. It makes them feel more comfortable. Even if you don't speak it perfectly, even if you're slaughtering some of your words, or you tell them, I'm sorry, you have to speak really slow. If you can understand what they're telling you in Spanish, that's amazing, or in any language. Sign language is a good one. I mean, just any language. If you can get to somebody's kind of base language, it shows that you've got the compassion there, and a lot of times it really helps the relationship.
For students that are looking into rural medicine, do you have any recommendations of or like internships they could look into or
So I don't know of any internships kind of at the undergrad level. Once you get into med school, there is a lot of draw to rural medicine because there's a lot needing in that area. A lot of people need to go into that area now because telemedicine has become more popular. It makes it a little bit easier. So perhaps there's a family practice doc in the middle of nowhere, Texas, and they don't have a neurologist. Well, now they can put their patient in front of a screen and get to a neurologist at maybe one of the big medical centers, and they can be assessed. Again, it's a little bit different to assess a patient on video than it is in person. So it makes it a little bit harder. But when you have a doctor when you have a doctor that's there, that's able to perhaps perform the examination that the attending doctor, or the specialist far away can see, that makes it a little bit easier.
okay. Well, Dr. Esparza, thank you so much for taking time out of your day to
Absolutely.
interview. We're really thankful about it.